My name is Alfreda Rooks, and I am the Director of Community Health Services and the Program for Multicultural Health at Michigan Medicine. Next slide, please. The content within this presentation is to serve as educational information. For more specific questions about your own health state or health status, please contact your personal care provider or a physician in your network. The information from this panelist was taken from the Centers for Disease Control, as well as the Michigan Department of Health and Human Services. Next slide. We want to thank our collaborative partners for supporting us in this endeavor. The Ministerial Alliance of Ypsilanti Ann Arbor Vicinity, the Rogale Cancer Center, Washtenaw County Health Department, Grace Fellowship Church, Messias Temple Church, the Turner African American Services Council, Washtenaw Community College, and the Community Family Life Center, as well as St. Joseph Mercy Ann Arbor and St. Joseph Mercy Chelsea. We also want to thank our partner, the Mishar Community Engagement Corps as well. So thank you. Next slide. On Friday, we celebrated the actual birthday of Martin Luther King Jr. On Monday is when the rest of the nation will celebrate. Dr. King asked a question in a book, where do we go from here? Chaos or community? What we have learned and what we have found with the COVID-19 pandemic is that there has been more chaos, and what we want to do is bring information to you today that will help us reach that community part. Please know that even though we're talking about specifically about the African American community today, it is in no way intended to mean that there are not health disparities that are experienced by other groups of color. Only that today's workshop will focus on the African American community, and we will have other things in the works as we move forward. It's very important that you complete the the surveys that we're asking you to complete, because they will form some of the next educational opportunities that we have. Next slide, please. It is my pleasure to now introduce the moderator for this afternoon's panel, Dr. Othea Pryor. Dr. Pryor is the project manager of the Pathways, Learners, and Leaders program through the Michigan Medicine Office for Health Equity and Inclusion. She's a founding member of the National Partnership for Action to End Health Disparities and the founder of the Michigan Minority Health Coalition. Dr. Pryor obtained a PhD in educational psychology from Michigan State University and an MPH from the University of North Carolina at Chapel Hill. The Michigan legislature awarded her 2 state Michigan Seals for her innovative work in minority communities. Dr. Pryor, thank you for being with us today, and take it away.
Good afternoon. We are so glad to have all of you participating in this important event today. As you know, COVID has ravaged our community, and we are involved in making sure that you have the information that you need to make the evaluation as you proceed forward to protect your health. The first thing I'd like to do is to read and, the first thing that I would like to do is to alert you to the fact that we have asked you to submit questions to our panel ahead of time, and the group has submitted some extremely thoughtful and provocative questions. So we will be glad to answer those after our 3 presenters complete their presentation today. Next slide, please. What I'd like to do first is introduce you to our panelists. We have 3 excellent panelists who are going to give you information and also a personal experience as to what their experience has been with COVID-19. Our first presenter is going to be Bishop Harry Grayson, and he is the pastor of Messias Temple Church in Ypsilanti. The bishop is the bishop of the 60th Episcopal District Council of Western Cape, South Africa. And he has had a great impact on his community, both locally and internationally. It doesn't only include his sermons and baptism, but also the work he has on We Care, We Share hot ministry program that feeds over 10,000 families a year, and his contribution to the development of a church and medical clinic in Zimbabwe. Our second presenter is going to be Dr. Kiela Samuels, who is a clinical pharmacist and researcher in the Division of Allergy and Clinical Immunology at the University of Michigan Health System, along with being the director of the Pharmacy Technical Program at Washtenaw Community College and the co-founder of The Pharmacy in Ypsilanti, Michigan. She is an active student educator and has been recognized for being both the Preceptor of the Year, and she's received that award, and the AACP Preceptor Recognition Award. Dr. Samuels obtained her Doctor of Pharmacy from the University of Michigan College of Pharmacy. Our third presenter is going to be Dr. Jessie Kimbrough Marshall, who is an assistant professor at the University of Michigan Health System, the former medical director of the Washtenaw County Health Department, and a public health researcher in the Institute for Healthcare Policy and Innovation. She completed her medical training and internal medicine pediatrics residency at Wayne State University, and she obtained a PhD from the Harvard Chan School of Public Health, and she completed a general medicine, internal medicine fellowship at Johns Hopkins University. So what we're going to do right now is we're going to start our presentations with Bishop Harry Grayson, and he is going to speak to you about his experiences he has had. Bishop Grayson, would you please unmute your mic and also show your video so we can hear what you have to say to our audience. Thank you very much.
Yes, good afternoon, everyone. It's a pleasure to be a part of this discussion today and sharing with you my story, a portion of it. And it's strange. My sister, who worked at a lab at U of M in microbiology lab doing specimens and the sort, I asked her to call the doctor for me so she could better articulate my needs and concerns. And they said, bring them on in. And that was the 1st of April, Wednesday. And that Thursday, they brought me in and they put me under anesthesia almost immediately. They saw, I vaguely recall, they did the called oxygen, the thing, put your finger, check your oxygen level. My oxygen level down to 80-some%. So they put me in, and my wife, in her wisdom, wrote down notes I recall she got because she was dealing with cancer at the same time under chemotherapy. So she wrote a timestamp log. On the 6th, they called and said he has to be intubated and moved to ICU. And the 3rd, I was resting. They were trying to wean me off intubation, but a number of things happened that to me was, I tell people in my congregation, if you're gonna go to the doctor, listen what they gotta say and obey their orders. Don't go to the doctor, then fuss with them and argue with them. But I was not to have an opinion. I was into chemically induced coma and intubated. And so my wife began to call some friends of mine up across the country that she knew I'd been talking to and asked them to pray with them, pray for me. So upon doing so, they began to put because you got a stent where they put it in for me to take dialysis. I was put on dialysis while my kidneys began to fail. And my wife's at home getting these calls every day. And I asked her, how in the world do you do it? And that's the part. You need a good support system. And I had a friend, also a member of the church, was in fact a nurse, was on the verge of graduating with her PhD from nursing. That was a great blessing because she helped us to understand what we were dealing with. And so by that Wednesday, the 8th, I was started on dialysis and I had a shortness of breath. I'm still unconscious. I don't know nothing. And what it was is just that I talked to a number of friends that had it like a cold or flu, stayed home and overcame it. But mine was very traumatic. Myself, my family, and the pastor of the church and congregation, but also the whole church world was going through. People were dismissing services for safety. So kind of played into our hand. I had a good staff that kept things going. And I came out of my unconsciousness and requested to hear my voice and my wife's voice. So when the nurses got an iPad and put me in contact with her. And they were, about that Saturday, the next week, they still weren't comfortable with removing the tube. And my white blood cells, all these medical terms the wife was getting and whatever it was. And that Saturday, I think Saturday before Easter, my wife called one of the nurses and asked her to pray for me, to go in my room, because nobody had access to the hospital then. It's in the hospital I was in. And I began to kind of respond to some degree, might I say. They took me off the ventilator that Easter morning, very befitting Easter morning, the resurrection morning. They took me off. And I came out my conscience, said, bring me some clothes. I'm ready to go home. But I wasn't ready to go home. And which means I was getting some sense of sensibility, you might say. They called a thing called delirium. I was on so much medication. I was out so long, I guess I was saying something that didn't quite make sense. And the greatest concern my wife had was about this we call it the dialysis. It would be permanent, because she knew it was one thing I never wanted in my lifetime. And so the battle was as such. I was in the ICU with someone like solitary confinement. I didn't see anybody. I didn't know anybody. I didn't know who was outside in the hallway. Some said you was on the same floor I was on. I didn't know what floor I was even on. So it's traumatic because I became like an invalid. I became weak. I lost 50 pounds. I couldn't even hold a glass of water to my mouth. I needed help to do the basic things of life, restroom, shaving, brushing my teeth, and so on. So it made me incapable of even caring for myself. It was quite humiliating, but I knew I needed the help. I called for dialysis, and I began to gain some strength. And then the major discussion was, is he going to rehab? Is he going home? And my wife and kids said, we will be his rehab team. So they sent me home in a wheelchair, 3 men to carry me out of the hospital, to carry me home. But what it was, some of the things that I lost, I wasn't aware. I was in a coma for 20-something days. So I had no idea of how much time it took, what I was going through, what state I was in, because I was in a coma. Like a fentanyl, one of those drugs they use. And it's like, do you remember anything? So no, I don't remember nothing. I felt nothing. I knew nothing. I was just out. It was a blank slate in that regard. I remember one of my staff said, I called them when I went in and said, I'll be out in a couple of days. I don't even remember that calling them. And it was a bit humiliating. COVID was, I know people that had double lung transplants, amputations, and here it is, 7, 8 months later, I'm still recovering. It's took away my capacity, my energy capacity. I get tired real fast. So they're still learning and they're still studying. Someone got the news, he said, he used to work 70 hours a week and now he washes the dishes and he goes to bed because he's so tired. COVID is a really strange disease. And most people I see, like a flu or something, they catch it and they at home, they have no taste, no smell, things of that sort. But one of my therapists that came by, was signed by the hospital to come see about me. He said, we don't understand yet. We're still studying it. We're still learning what it does to the lungs. It was degenerative. It takes away things, where it went and how it left and the effect of it. But we learned how to recover. And I came home, I couldn't even walk. I was in a wheelchair around the house, went from a wheelchair to a walker to a cane. My greatest concern was, how was I going to get out the front door or the garage into the car? And finally I did it. But I had to do it with assistance of someone else. I couldn't drive. Now I'm driving, I'm walking. But I'd be very careful when I go. I go to the store, like with Messias, a large store, I would use a electric cart because I can't cover that distance. I'll be wore up before I can get into the store goods. So COVID has affected me. I got most of my senses and strength back, but the endurance factor is not there. The strength to do things is not there, but I have been blessed to have a good support staff at home and at church. My wife, my kids, my members, the other ministers that help me out. I'm not an invalid. I'm able to perform a reasonable life. I'm not climbing ladders, I'm not going on the cars, I'm not cutting grass, things like that. But it's just a terrible disease. There's so many unknown factors that are yet being discovered. And so I went through a number of medications. My wife said, a friend of mine said, tell the doctor that the medicine President Trump was using, he told her about that. And the doctor said, we've tried that for the last 5 days and no response. So they were trying different things on me. And some of the things I vaguely recall, I don't want to repeat now, they tried, and thank God at one point, they lost all signs of life. No blood pressure, no heart rate, nothing. There was moments away from sending me to the morgue. And one of the nurses came in and looked at my charts and said, you haven't given him his meds for the day. Maybe he's going to a stroke. And she suggested to send me to a CT scan. And they discovered there were still signs of life in my brain. I just turned there, cleared a pathway for me to go to the morgue, but they stopped it and found signs of life in that contained. So here I am today, alive and well, and I'm still dealing with the COVID. And and the closer I get to this vaccination, rumors are flying rampant in that regard. But I've heard people that had COVID that was considered some level of, we call it resistant to the strain. But eventually when it wore off, they found them dead in another room somewhere. So I personally am looking forward to take the vaccination. I'm looking forward to my life back. I realize again, at my age, I've been blessed a long life of health, doing well, and here I'm today facing the challenge of being on dialysis, but I'm looking forward to being completely delivered from that as well. I can't travel as free as I did before, and COVID took some things from me, but I'm asking God to deliver me and restore me, my strength, my life, and my ability to function in my call. And at one point, I figured my life was over. I was going to retire and quit. And this strong voice or urge came in and told me, your life is not over with yet. They had me intubated. So everything happened so fast. I didn't have all the cold, no taste. Am I on still? Are you picking me up? Are you picking me up?
Yep, we can hear you now.
Okay, great. So that's all. It's a lot. I have a great support. It's something we as a country have to deal with. So I thank you for being a part of this discussion today. It is real. And we need all the support we can get in dealing with this stuff. My family, my granddaughter, even now, she gets scared and starts crying. She sees me coughing because she knows how close she came to losing her grandfather. So I bless God today for being a part. And thank you so much for allowing me this short time to share. Thank you.
Thank you very much, Bishop Grayson, for sharing your miraculous story of your survival, your faith, and your journey with God's grace in your life. We also pray for your recovery and that you're restored so you can continue to do the work of the Lord that you have been doing all of these many years. Thank you very much.
Thank you.
Our next panelist is going to be Dr. Kiela Samuels, clinical pharmacist, Division of Allergy and Clinical Immunology at Michigan Medicine.
Well, good afternoon, everyone. I am so excited to be able to share some very important information about the COVID-19 vaccine. You all have seen this slide. You've seen this picture. This is an artistic representation of the coronavirus. This is the enemy. And you know, anytime we have an enemy, we need some weapons. And the weapons that we have had going into this and when it started was wearing our masks, right? We all were masking up. We were washing our hands, social distancing, boosting our immune systems up with good nutrition and vitamins. And of course, we have been praying. And now we have another weapon, and that weapon is the COVID-19 vaccine. So what I'm going to do is give you an overview of vaccines and how they work. We're going to specifically talk about the COVID-19 vaccine and then look at the side effects.
How would COVID vaccines work in your body? Well, I have 60 seconds to tell you 3 things you should know. Ready? Number 1, getting the immune system in shape. A vaccine is basically a training session for the immune system. Vaccines teach the immune system to look for the key features of a virus. So when a virus does show up, it's ready to fight it off. Number 2, vaccine, meet virus. The vaccine gives your body a plan to recognize the virus. Then your immune system starts preparing by making antibodies, or fighter cells, that stay in your blood as protection in case the virus tries to invade. What this means is you get immunity against the disease without having to get sick first. Number 3, immunity, immunity. When enough people's bodies know how to fight off a virus, it has nowhere to go. That slows the spread. When people get a vaccine, we're able to stop the spread quicker and get a little closer to ending this pandemic. That's basically how vaccines work. And that is 60 seconds.
All right, and that's what we want to do. Our goal is to end this pandemic.
How would COVID?
So now that you know how vaccines work, we have seen vaccines traditionally, right? Every year we get our flu vaccine. That is an inactivated, dead type of vaccine. And then there's also weakened vaccines that are live, like measles and mumps. Next slide. But now there is a new type of vaccine on the horizon. Let's look and see the traditional vaccine versus the mRNA vaccine. So traditional vaccine, the components, we take a part of that microbe, the protein piece of it, and we take that and we're trying to find the right type of protein in production. And this is a slow process, and it's more difficult to produce. As you know, like with the flu vaccine, right? Every year we're studying the different types of flus that are out there and making sure that that flu vaccine has effective virus for that particular year. So this is kind of a long study process. And so the next thing, we take those components and they're made in the lab, and then they're injected in the arm to stimulate the immune response. So the vaccines that we have on the market right now are the messenger RNA vaccines. So the messenger RNA vaccines, can you go back to the next slide, are vaccines that are using a blueprint. So we have a genetic code. The blueprint to make a protein is not the actual virus or bacteria. This is making the production a little bit faster, and the mRNA is easier to produce. So the process is that you take this and it's injected in the arm, and your body makes its own protein and uses the mRNA code. Now the next slide. Okay, so we have the mRNA protein that's injected into the muscle, and then the vaccine triggers the production of the spike protein. So you saw that coronavirus, remember that? Those little red dots, those spike proteins, that will start to be produced in your body, and then antibodies specific to that protein are made to fight off the coronavirus. Next slide. So these are some key facts that I want you to keep in mind when we're talking about the mRNA vaccine. The mRNA process has been studied for over 10 years. So we had some information. There was some research going on with messenger RNA long before COVID even hit the scene. So that's not a new kind of process. But the mRNA vaccine does not use a live virus, and the virus cannot give someone COVID-19. So these are different important points that you need to know. Also, the mRNA vaccine does not affect or interact with DNA in any way. That's another thing that people kind of think about. What else is it doing with my body? So it's not affecting and interacting with your DNA. But the COVID-19 vaccine is held to the same safety standards as all other vaccines. So let's look at some of those standards. Next slide. All right, this picture here, this slide looks at the clinical trial phases. So in phase 1, you're looking at safety. So what the researchers will do, they'll take a small sample size of healthy volunteers and they'll look at safety. We want to make sure that it's safe and it's not going to do really harmful effects to you. Going on to phase 2, we starting to look as, is this vaccine, is it effective? So we'll take a sample size of about 100 to 300 volunteers and we look at the effectiveness of the product. Phase 3, this is when we get really excited. Oh, we've done all this research. Oh, you always hear this in the news. Now we're entering into phase 3 clinical trials. And phase 3 clinical trials is looking at the efficacy also. But now we're doing thousands of volunteers, thousands of study participants. And then phase 4, oh, voila, the vaccine is approved. And at this point, we're going to continue to monitor and we're going to analyze it when it gets to the market. We'll do post-marketing surveillances and we'll get more information. So those are the 4 phases of clinical trials. Next slide. The 2 vaccines that we have currently on the market for use right now is the Pfizer vaccine and a vaccine made by Moderna. Next slide. All right, let's delve into the clinical trials a little bit more. So the Pfizer BioNTech had almost 44,000 participants enrolled. And look at the Moderna. We can do this side by side here. So they're very similar in their mechanism of action as to how they work. And we have 30,000 enrolled in the Moderna study. So anywhere from like 89 to 150 clinical sites, 32 to 39 states. And when we look at the racial ethnic distribution, you can see that both studies had 10% of their study population were African Americans and 45 to 65% of the participants were older than 45 years old. Next slide. So this was my big question. Clinical trials. This was kind of fast, right? That's what everybody was saying. We was hearing in the news, warp speed. It was fast, so is it safe? So I already told you, we had already started studying about messenger RNA many years ago, right? Anywhere from like, over 10 years. So the researchers shared that information. They shared that data and started to begin conducting the COVID-19 vaccine trials. Now, this is how we were able to get this to market quickly. This is one of the key points. Manufacturing started to begin while we were in the clinical trials were still going on. So typically, you remember the slide with all the phases? Typically, we are going to wait until all of the phase 3 data is in and all that information is in before we start manufacturing. We started manufacturing this product at the same time we were finishing up these clinical trials. So that's where we, got a little bit of the time shaved off, but all the steps were there. So another good point is that mRNA vaccines are faster and they're cheaper to produce, but we had a lot of people looking at this. There were government monitored clinical trials. So We had the government involved. We had the FDA and the CDC prioritizing and reviewing the authorization of the COVID-19 vaccine. So every single safety standards were used for these vaccines. So this was a relief for me. Okay, so looking at the COVID-19 vaccine, the mRNA coronavirus vaccine will consist of 2 doses. So you have a first dose, and then anywhere from 21 to 28 days, depending on which vaccine you use, you will get a second dose. So the second dose is like a booster. So you need both vaccines. So if you decide that you're going to get this vaccine, it's going to be very, very crucial for you to go back for your second dose so you can have complete protection. And then after you do the second dose, about 1 week, you'll have complete protection. Next slide. All right. This is a super, super critical slide here. What are the adverse effects or the side effects? And then what's abnormal? So let's look at the normal or expected effects. So most people that were in that clinical trial, they felt some fatigue, they had some headache, they may have had some chills. Muscle pain was a big one, even with some of my colleagues here at the Allergy clinic. We've been getting our first doses, and actually a couple of our physicians now have gotten their second dose. And many of them said, my arm hurt for about 24 hours or so that muscle pain. As we get into that second dose, we are expecting maybe that some of these symptoms can last a few days more than, the first dose. You might see them, if you didn't have anything in the first dose, you might see something in the second dose. So that's how it was in the clinical trials, but we will see. Now, that's expected. Let's look at the allergic response. So this has been in the press a lot these days about people that have allergies and what is an allergic response. So those are side effects. An allergic response is when your eyes may get itchy and your nose and throat may be itchy. You may have difficulty breathing, or you get a skin rash, sudden nausea, vomiting, the chest may feel tight, or you get flush or faint. In rare cases, patients will have an anaphylactic reaction. Now, the anaphylactic reaction, that occurs when a patient or a person is so hypersensitive to that particular product. But this is very, very rare. And trust me, everybody who is putting that shot in your arm, they have safety protocols and they have medication right there to help you with any problem if you had it. So just knowing adverse effects and what allergic responses are, they're very, very, very different. Next slide. The COVID-19 vaccine is very effective. In both trials, we see 95% effective rate at preventing COVID-19 with the 2 doses. Remember, 2 doses, you got to get them both. We're not really sure how long the protection is going to last. So we're going to take some more studies, and remember I talked about those post-marketing surveillance. We'll know more as time goes on. And as you saw in the previous slides, both vaccines were tested in very diverse populations, older people and people of color. And even people who've gotten COVID-19, like Bishop Grayson was talking about to us, may still benefit from getting the vaccination. Next slide. So who's eligible for the COVID-19 vaccine? So I'm a part of healthcare workers, and as you can see, I am sitting right here at my Michigan Medicine Allergy Clinic, and many of our co-workers, physicians, nurses, me as a pharmacist, have gotten our first dose of the vaccine. But as of Monday, Michigan has entered into the next phase. So now people who are 65 and older, those frontline workers like the firefighters and police and all those folks have been added to be eligible to get the injection. Our childcare and our teachers. I've had many of my colleagues who are in teaching calling me, asking me about the vaccine because they're just like you, want the information, wanting to know what's my next step. Should I get the vaccine? And congregate care facilities are now eligible. Next slide. So what should I expect? So before, you're going to learn about COVID-19 vaccines. And I applaud you. I applaud everyone who registered and who is on this Zoom call right now because you're getting the facts. You are the person who you're going to be in the know. So learn all you can about the COVID-19 vaccines. Then you're going to see if the COVID vaccine is recommended for you. This is going to be an individual decision that you're going to make with your healthcare provider. So that's what you do. When you make that decision, I want you to read the fact sheets. There's lots of information that's out there that will tell you even more specific about the COVID-19 vaccine that you're going to receive. And then you're going to get a vaccination record that looks like this. So you've probably seen many people getting the cards, posting them on Facebook and sharing their journey through the process of getting the COVID vaccine. So as I said, you're going to need 2 shots. You should know about what the side effects are, like I explained, and then you can enroll in something called vSafe. So vSafe is set up by the CDC, and I enrolled in it actually just this morning, just a couple steps on my cell phone. And this is a way that the CDC can get additional information. That's another thing people are asking, well, how are they going to know about me? Well, I got the vaccination, and so I'm experiencing maybe this problem or a side effect or what's going on with me. This is a way that we can get information. And if you're doing well, then all of that is also recorded. So you need to continue to make sure that you're protecting yourself with all the measures that we have in place. Remember, coronavirus is the enemy, and we have to have our weapons. So our weapons, we're going to continue to wear that mask. We're going to wash our hands. We're going to continue social distancing. We're still going to boost our immune system and take our vitamins. And we're still going to pray. And we're going to pray for Bishop Grayson to continue to get well. We're going to do all of those things. Next slide. And this is me. I received my first shot back on January 4th. So it's just been just a couple of weeks here. I'm due for my second dose in a couple of weeks. And my story, I had to go and talk to my care provider because I was not the typical patient that was in the study. I have an autoimmune disease. I have lupus. And I have a compromised immune system because of the medications that I take to manage my lupus. So after having conversation with my rheumatologist, we thought that it would be best for me to take the vaccine. So you look at the risk, you look at the benefit, and if the benefit is greater than the risk, then you take the vaccine. And I am so excited. I'm doing well. I just had a little arm pain. I'm great. I'm so excited that I was able to share these little nuggets of information about the vaccine. And I hope that you will have a very, very safe journey also. Thank you.
Thank you, Dr. Samuels, for your story and for giving us the information about COVID. I also am scheduled to get my first shot of the COVID vaccine, or my first shot of the vaccination on Monday. And I'm really excited. And I will also be putting my card on social media saying that I was vaccinated because we need to be armed. We need to be armed with the weapons that will protect our health and protect our society and our community from this ravaging disease that has been so devastating.
Amen.
Our next and our final presenter is going to be Dr. Jessie Kimbrough Marshall. And she is the Adjunct Assistant Professor, Division of Allergy and Clinical Immunology at Michigan Medicine. And she's going to be giving us some more information. Thank you.
Thank you. It's my pleasure to be here with y'all, spend some time talking about such an important topic. And what I will be talking about specifically are COVID-19 racial disparities. Next slide. So COVID-19, Black, Latino, and Native Americans have borne an unequal burden for this pandemic. Communities of color have been disproportionately affected by COVID-19. People of color get sick and die of COVID-19 at rates higher than whites and their share of the population. Next slide. Blacks are 30 times more likely to die from COVID-19 compared to Asians and white Americans. Next slide. And when we look state by state, and this data comes back from April of 2020, we see the same story. For instance, in Louisiana, Blacks, African Americans make up 32% of the population, yet they accounted for 70% of COVID-19 deaths. And here in our state of Michigan, Blacks make up 14% of the state's population, yet accounted for 41% of COVID-19 deaths. And so there was, some questions as to, well, why are we seeing African Americans and Latinx and indigenous populations disproportionately die from these COVID-19? And some of the immediate causes were readily identified. Well, Blacks and other racial and ethnic minorities are disproportionately with higher rates of chronic medical conditions like high blood pressure, high cholesterol, diabetes, kidney disease. Next slide. And then also Blacks and other racial and ethnic minorities have disproportionately higher rates of poverty. And that manifests into having a higher reliance on public transportation, needing to more frequently shop for basic necessities, having jobs that are low wage or temporary jobs, not allowing for working at home and telework, and not having provisions for paid sick leave. And then also distrust in these communities of color, of public institutions and healthcare system and public health infrastructure. And so there are some who said, well, why is that? Why is it that racial and ethnic minorities like Blacks and Latinx and indigenous populations, why are they disproportionately with chronic medical conditions? And why are they disproportionately affected by poverty? I know that prior to me going to medical school and prior to going into public health, those were some of the questions that I asked growing up in Detroit, Michigan. Why are we so disproportionately impacted by all of this? Well, when we look at some of the root causes, or more specifically, some of the factors that shape health, I love to use this slide from the Robert Wood Johnson Foundation because I think it perfectly outlines all those factors that shapes one's health. Next slide. We see the two rungs at the top account for most of that shaping. They account for most of the space, most of the impact as to how one's health is formed. And what those two rungs represent is economic and social opportunities and resources, in addition to a living wage and working conditions in homes and communities. These two rungs represent the most impactful social determinants of health. And so for me, as a physician, particularly when I worked in primary care, health of my patients, especially my new patients who came into my office, their health was on a trajectory long before they saw me, long before I may have prescribed them something for high blood pressure or diabetes. Where they lived, where they worked, where they prayed, all of those factors, all of those socioeconomic factors shaped their health long before they saw me. And as far as personal responsibility and personal behaviors, yes, absolutely, it impacts one's health, but you know, there's this saying that I learned back in training, when as a society, if we expect for individuals to make personal responsible decisions, then there must be responsible societal options for them to make their decisions from. And so when we think about what are the root causes that shape the social determinants of health, again, this has been a question that I really was interested in answering early in my career because of my personal life experiences, as well as my professional observations. And when we talk about what are the root causes that shape the social determinants of health, particularly for people in communities of color, we need look no further than, next slide, the historical legacy and continuation of structural racism, and how that shapes the social determinants of health for individuals in communities of color. Next slide. And when we talk about social determinants of health, yes, we're talking about the economics of a community and how stable it is, the educational access and quality, particularly for public education, K through 12, the neighborhood environment, the built environment, the social and the community context, as well as healthcare access and the quality of that healthcare. Next slide. So I just want to take one moment to really expand the discussion about those social determinants of health and the root causes that affect them, that have shaped them. And so we can use the example of a housing policy. This slide here is a map of Richmond, Virginia. It's a federal government map of Richmond back from the 1930s. And what this map shows us is that neighborhoods were outlined and colored in red and considered to be risky for mortgage lenders to offer loans to, hence the term redlining. And if I asked you, who do you think were the populations most concentrated in these red areas? Just take a guess. Who do you think that was? Well, I'll tell you. Blacks and immigrants. Those areas deemed risky and not worthy of mortgage lending to offer loans were communities of color, specifically Black communities, as well as communities with immigrants. Next slide. And so the long-term effects of such discriminatory housing policies made it difficult for communities of color and immigrants to buy or refinance. And this lack of investment for decades meant houses fell into despair and neighborhoods fell into despair. And these discriminatory housing policies helped to concentrate poverty in communities of color for generations. I want you to think about how here in the United States, public K through 12 funding is based on. A large part of that funding is from the tax base of those individuals in the community. And so when we look at communities of color and we look at also this concentrated poverty, it's no wonder why we find in city after city after city that communities of color have K through 12 public education that is afflicted by being lower resourced, very much so challenged and compromised with their academic quality. Next slide. Now, I want to move on into the history of unethical medical experimentation and exploitation, and in addition to that, healthcare disparities. So when we talk about racial and ethnic minorities here in the United States, in particular, having mistrust or distrust of public institutions, and of course, we don't mean all racial and ethnic minorities, but just in general, we talk about these communities having distrust. It's founded. It is founded. And a lot of us will readily point to the Tuskegee syphilis experiment that occurred for over a 40-year period that was sanctioned by the government and involved public health and healthcare physicians and scientists who fooled Black men who had been infected with syphilis. They fooled them into thinking that they were receiving treatment. But when in reality, they were not, because these researchers, these scientists and physicians, they wanted to study and see what were the effects of syphilis untreated in the long term. Every time I talk about this study, I just get a chill. And then Henrietta Lacks. I had not heard about Henrietta Lacks or the HeLa cells or her story until I did my fellowship at Johns Hopkins. And what I came to learn, and I find that many others are aware of, is that Henrietta Lacks was an African-American woman who in early 1950s, late 1940s, early 1950s, was diagnosed with cervical cancer. She subsequently died from cervical cancer some short months later. But the thing is that researchers collect her cervical cancer cells, and those cells, they're called HeLa cells, they were able to be replicated over and over again. And for over the next several decades, researchers studied these cells, and they have been deemed some of the most important contributions to medical research findings. But there's a problem. Henrietta Lacks was never asked, would she donate herself? And furthermore, her family, after her death, were never asked, was it okay for her cells to be used in research? Unbelievable, right? And then the unequal treatment. This was a landmark study that was commissioned by the Institute of Medicine, which is a nonpartisan, non-governmental healthcare authority for our country. Back in 2002, and just prior to that, it convened experts from all over the country, experts in racial and ethnic healthcare disparities. They convened them to study how much of a problem were healthcare disparities here in the United States. And what these experts found was that there was documentation of decades of healthcare disparities within our healthcare system, as well as healthcare outcomes. And that continues today. So with that very troubling history, here we are. Here we are in the midst of one of the worst pandemics we've ever seen. The disproportionate impact of the COVID-19 pandemic, particularly on communities of color, and particularly on African Americans and Blacks, it cannot be understated. African Americans and Black folks have more rates of infections with COVID-19, hospitalizations, deaths, and then the economic fallout has been especially hard in terms of food insecurity, not having enough food to eat or not knowing if you will have enough food to eat, housing insecurity with threats of eviction or not being able to pay your rent or your mortgage, and remote learning disparities in K through 12 public education, with children in our communities having more or worsened disparities in their educational process with having to learn at home. And so while we have so much troubled history with how we have been treated in this country, we have been so disproportionately impacted by this pandemic. It has really caused a crisis within a crisis for communities of color. And so here we are. What are we to do? Well, we know that early in the pandemic, it was announced that researchers and scientists all over the world were busily trying to develop a vaccine to combat against this pandemic. And Dr. Samuel so wonderfully spoke on how it was developed and the technology behind it. But yet, there were reports of surveys of people all throughout the United States, irrespective of race and ethnicity, who had a lot of doubts and hesitancy and concerns and distrust of taking the vaccine. And there are a lot of folks who said, I'm not taking it. And this sentiment was even more magnified in communities of color, say like Black folks, and for many of the reasons that I had just previously described. Well, next slide.
2 minutes.
Thank you. I want to spend a little bit of time talking about the vaccine process as it relates to diversity, equity, and inclusion. So why is this important? Because diversity produces, when the clinical trial participants are diverse, that helps to produce better science, and it also helps to build trust. Next slide. As Dr. Samuels had pointed out, for the Pfizer clinical trial study, 10% of participants were Black, 13% Hispanic, and 1% Native American. And with Moderna, similar, with 10% Black participants, 20% Hispanic, 3% other ethnicities, and 4% Asian. Next slide. And one thing that I was particularly heartened by was the involvement of physicians, scientists, and researchers who look like me, who were Black, who were African-American, involved internally and externally. So we have Dr. Kiela who works at the NIH, the National Institute of Health, and is a viral immunologist who has been integral in terms of the development of this new technology behind the vaccines. And then we have Dr. Valerie Montgomery Rice and Dr. Obetta Fuller and Dr. James Hildreth, who the last two in particular sat on the Food Drug Administration FDA advisory panel that gave oversight and review of the clinical trials and all the data related to the two currently available vaccines, and with Dr. Rice being a staunch advocate for diversity and equity initiatives in promoting equity. And then the National Medical Association, the NMA, one of the largest Black physician organizations here in the country, creating a task force over the vaccine development to take the politics out and to just give the facts to communities of color. Next slide. And then I want to end with, how will the vaccine be a benefit to you, to us, to me? Well, it will help keep you from getting COVID-19, the disease. It may also help protect the people around you, your loved ones. There's still a lot of research going on about how that might be possible, and if it is possible. And also, getting a vaccination is a safer way to build protection, to build immunity, versus getting infected with the coronavirus. And then the vaccines are an important tool to help stop the pandemic. Next slide.
1 minute.
Thank you. So getting vaccinated, wearing a mask, staying 6 feet apart, and washing your hands, all are important tools to fighting this pandemic. Next slide. And I'm happy to report I received my first dose of the COVID-19 vaccine on January 4th as well. And I'll be getting my second dose very shortly. And I'm also happy to report that set aside from some mild arm tenderness and a slight headache, I've been doing just fine. Next slide. And lastly, there's a lot of information out there on the internet. And there's a lot of word of mouth. And sometimes that word of mouth might not necessarily be bringing the most evidence-based, the most up-to-date and scientifically backed information. And so I would implore you, look to the following to get your sources of information. These are trusted sources of COVID-19 information with the most up-to-date, the most available information. And that's the CDC, the Center for Disease Control and Prevention, the Michigan Department of Health and Human Services, and your local city or county health department. Now, we do understand that because this virus is new, information is and knowledge is steadily being learned. And so please understand that as more knowledge is learned, recommendations and information will evolve. So you want to look for information, look to these sites. Thank you so much.
Thank you very much, Dr. Marshall, for your insightful presentation and also your personal story of your experience with the COVID vaccine. We have multiple questions that the participants who are involved in this webinar have asked, and we're so glad that you're engaged in this topic, and because it's such an important topic, especially for our community. So we won't have time to answer all of your questions, but I want you to know that this conversation is going to continue at various levels. There are going to be future webinars. There are going to be future sessions on this and other areas of interest that will be targeted for our community. So let me ask the one question that is a question that came up multiple times that people are asking. Individuals want to know, well, if I get the vaccine, how long is the vaccine going to last? How long is it good for? So I would like to ask our panelists to answer that question, please.
All right, this is Dr. Samuel. So we don't know yet. I did put that in the information. We're going to find out as we hear more, get more data in. You remember at the beginning of COVID when we kept saying, we need more people tested, test, because we're scientists, we love data. And so as we get more information, we'll be able to answer that. But that's one of the things we don't know.
I thank you for that answer. And I think it's very important that we're honest and we relate to our community what we know and what we don't know, because that's the only way individuals will be able to trust the information that we're receiving about the coronavirus. Okay, let me ask another question. There was a lot of questions where individuals were talking about allergies, and they were talking about specific allergies that they had, specific symptoms and allergic reactions they had to food and medication. And I know, Dr. Samuels, you covered a lot of that, but would you reiterate what you would recommend for individuals who have allergies and are considering taking the COVID vaccine?
So if you have allergies, the allergy associations out there are recommending that you do get the vaccine. However, I will tell you, just like I had to make a decision with my physician, I will recommend that you talk to your primary care doctor, or if you're seeing an allergist, you know, if you have severe allergies, you probably have an allergist. So call that allergist and get their recommendation as to what you should do for your particular situation. I will tell you also, I am involved in some clinical research here with our allergists, looking at the different components of the vaccine and allergy. So again, this is an ongoing process. We're learning more, we're researching. So the big thing for us is to have these discussions. And these are wonderful questions that you need to ask. And so let's keep talking. Let's talk to the people that are in the know, right? And that's your physician, and that's your pharmacists and nurses and all the different healthcare disciplines that are involved in process and in research.
Thank you. Dr. Marshall, I'd like to ask you a question. When I was looking in the chat and looking at some of the questions that were submitted beforehand, individuals were giving us specific diagnoses that they might have. And so someone was saying that they may have a heart condition. Someone else was saying that they may have sickle cell anemia, and they were wanting to know what they should do as they make the analysis of the benefits of the vaccine and their concern about the health conditions that they have. Could you speak to that as a physician, please? What would you recommend?
Yeah, thank you. Just as Dr. Samuel said, I would recommend that anyone with health problems and questions about is getting vaccinated right for you, to talk with your primary care provider. And if you don't have a primary care provider, I would urge you to go and talk with, contact, I should say, your local health department to help get connected with the healthcare provider and to help better understand what are the risks versus the benefits of you getting vaccinated.
Thank you very much for that. There were also questions or concerns because we know that right now there are 2 vaccines that are approved under emergency usage by the FDA, and more are coming. But right now we have those 2, Moderna and Pfizer. And individuals were wanting to know which ones should they take, or if they even have a choice of which ones they could take. So would either one of you like to address that issue?
Yeah, I'll take that issue. So the 2 currently available vaccines are very similar in terms of how effective they are at preventing COVID-19 disease, as well as their safety profile. And so my recommendation for anyone who is seeking to become vaccinated, whichever one is available to you, I would go with.
Okay, thank you.
Agree.
It sounds as if both of our panelists agree, and I would say I third that. If there's such a thing, I agree with that also, because what the choice we have is the risk from getting COVID and the long-term effects, and they're very variable, and we don't know if a person would have a mild case or a severe case. As Bishop Grayson had a very severe case, and we just don't know. So the choice we have is really the vaccine, which we know is a benefit or the potential of getting COVID vaccine. And so that's really the risk that we're looking at. Let me see another question that has been asked in this presentation. Oh, there's a question. This is one that's in the news. The question is this: does the vaccine guard against mutation? Because as we know, there's mutation that is occurring on the COVID vaccine. And we want to know, at least everyone really, the panelists, could you speak to that? How is the COVID vaccine we have now in terms of the mutated strands that are starting to occur in our population?
Who do you want to take the question?
So right now we know that there was, I believe it was in the news that it was a gentleman in Colorado who had a different strain. And as they're looking at him and studying this new strain, the researchers are believing that the COVID vaccine will help, but that may not be the case. I mean, we are dealing with something that it is unknown. And we know for a fact that viruses can mutate, right? So one is a good thing about messenger RNA. Let's say that we get a strain and then our new vaccine is cannot protect it. It will be, once we figure out the genetic code, because it's made synthetic, we can write a new script, a new blueprint. Remember the blueprint? We can get a new blueprint and quickly get another vaccine. So that's the cool thing about the mechanism of action of messenger RNA. So again, it's a moving target. The whole year, 2020 and 2021 is a moving target, right? So we get our information and we make the best educated decisions that we can make based on evidence practice, evidence-based medicine. Let's put it that way, evidence-based medicine. And when we get the evidence, then we can make better decisions at what will be the next step. So what we're saying today is today, and tomorrow's tomorrow.
Thank you, Dr. Sanders. Marshall, I'd like to ask you a question that has come up frequently in the news and also in just talking to individuals about the vaccine. The data shows that the vaccine protects us against getting the disease, but we're still told that we need to wear masks. So could you really explain why, if we have the vaccine, we still need to wear a mask for protection of ourselves and other people?
Yeah. So what is known in the scientific community is that the two currently available vaccines, they help stop the replication of the virus if one should become infected with the coronavirus. And so what that means is that the vaccines will help stop you from getting the disease, the COVID-19 disease. So it will help stop you from getting sick. And potentially it will help stop you from dying from or having severe complications. What is not clear yet in the scientific community is, will the vaccines, the currently available vaccines, will it help stop the spread of COVID-19? And so until that question is answered, it is still highly recommended that even after you get your vaccination, your 2 doses of vaccines, that you continue to wear a mask, cover your nose and mouth, and wash your hands frequently, and social distance, avoid large crowds, and not have people in your home who don't live in your home. So those are the reasons why you still need to follow those public health recommendations.
Thank you very much for explaining that, because that is confusing. Many people feel that, well, have stated, once I get the vaccine, well, then I can go back to my life as usual. And I don't know if we're ever going to experience life as it was pre-COVID. I hope so, but we just don't know. I have another question that the participants wanted to know. We've heard of this thing called herd immunity. And with herd immunity, we're just not really sure, what does herd immunity mean? And when we're looking at the coronavirus vaccine, how many people have to be vaccinated for there to be herd immunity? Could either one of you could tackle that question?
I'll jump onto it. So the latest I've heard, and that was coming from Dr. Anthony Fauci. Well, let me say first, what was said was that if we could get about 70% of the US population vaccinated, that should be high enough to provide herd immunity. I heard that number go up a bit more recently in a news report that Dr. Fauci was giving, and he talked about maybe 80%. If we could get 80% of the general population vaccinated, that could provide this herd immunity. And what herd immunity is, and I think the video that Dr. Samuel showed at the beginning of her presentation, it spoke about that. If enough people in a society, in a community, get vaccinated against a disease, then that helps to lower the amount of disease in the community. And therefore, even those individuals who couldn't get the vaccine, they still get some protection, because there are enough people in the community who are vaccinated and who, because of that, have lowered the overall amount of germ in the community. It protects everyone.
Dr. Samuels, thank you for that, Dr. Marshall. Dr. Samuels, would you like to add to that explanation?
I was just going to say that I agree. That's about the statistics that I was reading on just yesterday about herd immunity. And so again, there were people early on that were like, oh, I want to get COVID, just get it over with. And so herd immunity can start. All right. So thank goodness we have the vaccine. Yes. And now that piece is going to help that process get there faster, right? And we want to prevent, right? So the more people that we can get the vaccine, the quicker that we can get to herd immunity. So that's the goal.
Thank you very much. I was reading an article, and they were saying that the way our communities are segregated. Most African-American people live in African-American communities with other African-American people. So if we as a community are not getting the vaccine, then our community will continue to be plagued by COVID. And both of the presentations, especially Dr. Marshall, spoke to the fact how COVID has had such a disparate effect and impact in African American communities. So this gives us the opportunity, as you've explained herd immunity, it gives us the opportunity to take control of that and make sure that the disease dies in our community and we're no longer exposed. So there are many other questions, but we're coming to the end of our webinar. So what I'd like to do is turn this over to Elfrida Brooks and recognize that there are going to be more community conversations, more examples, more explanations about this. Thank you for participating in this event. Elfrida Brooks.
Thank you, Dr. Fryer, and thank you to all of our panelists. The information that you shared today, I've been getting texts from on my personal cell phone from friends who are on the line saying that the information was presented in a way that everyone could understand it, and they were just blown away by the information that you had and how it was broken down so that anyone could understand it. So we thank you very much for your presence and for sharing your time with us today, to all of our panelists. I want to just take you back to the beginning where we said that the purpose of this was to share science-based factual information to help you make the best decision for your health and for yourself. We hope that you've heard something today that has either allayed a fear or provided you with more information in order to make that decision. As another reminder, please complete the survey at the end. This is our evaluation. We knew that there were so many more questions that we could answer in this time frame. We want to make sure that we capture as much information as we possibly can to help us plan for our future events. And there's one more thing I'd like to say is that when we do this as a community. Next slide. And so I want to share with you an upcoming event through our partner from the Michigan Institute for Clinical and Health Research, their Community Engagement Corps. On Monday, January 25th from 6 to 7, there will be a community conversation. It's a statewide Q&A session. So if you have questions, other questions that we may not have answered here, or other things occur to you after this event, here's another opportunity for you to be able to ask those questions and get expert feedback from those things. It'll be broadcast in Spanish too, and also for interpretation will be available as well. Next slide. So the question at the beginning was, where do we go from here? And I think it's very important for us to remember that health disparities in people of color, within the people of color communities existed long before the pandemic happened. The pandemic just shone a light on it. So where do we go from here? We continue to work toward eliminating those health disparities and increasing health equity among marginalized groups. And how can we do that? We can do that by first being involved, by secondly, monitoring and taking care of our health, and by thirdly, asking questions. It's very important that you ask questions and that you, when you're going into your primary care provider, that you have questions that are important to you to answer for your health. So once again, I'd like to say thank you to everyone who spent time with us this afternoon. And one more reminder to please fill out that evaluation with those questions. And we look forward to seeing you at our next opportunity. Thank you and have a good day and be safe.